Yo, yo, yo. Hey guys, welcome back to another amazing edition of the Best Practices Show podcast. Happy Friday, everybody. I hope your week has been an amazing one. And every Friday, our job is to keep you at the top of your clinical edge, to give you something to think bigger and better about how you take care of your patients. And there's a lot of talk about the oral systemic link. But what about the oral systemic myth? And there's nobody better to give us some insight on what that means than Katrina Sanders. And she's doing an amazing course at our headquarters in Milwaukee that you don't want to miss. She's going to talk about that, but she's really going to explain, if you get this right, you're going to change not only your patients' lives, but all of your team members' lives too. So please listen to this. I hope you guys enjoy it, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. I'm so grateful you guys are showing up. I don't know how this is working. I don't know how you guys are sharing it, but the podcast keeps growing, and I'm going to keep bringing it. With over 800 episodes, we have 8,000 more, and you're going to see this amazing woman on this podcast multiple times because we share the same brain, except she got the good part of the brain. And we are going to be talking about some pretty cool stuff. And one of the things that's come into the world of dentistry, I call it one of the biggest disruptions and biggest opportunities in the same vein, is the oral systemic conversation. Now, today we're going to be talking about the oral systemic myth with the great Katrina Sanders. Thank you for being back.
Thank you. And by the way, I feel like everybody should introduce me as the great Katrina Sanders. Like, whenever I walk into the great Katrina Sanders.
The great Katrina. Like, I was joking with her. I always do a pre-show with everybody. I'm like, I want to be in your entourage one of these days. Like, I'm going to go to the restaurant a half hour before she gets there and go, the great, whatever. You know what I mean? We want that table, you know. I don't know. It's so fun to have you back. You are one of the busiest people on the planet. You're one of the most amazing speakers. Now, I'm just going to say this because I say this about you all the time. We love you here, the ACT team. You're just not only entertaining, you're brilliant. You incorporate the research, the verbal skills. There's very few people that can do that when presenting. Like, some of them might be able to present the research.
A snoozer, yeah.
Some of them could tell jokes, and you're like, where are you going with this? Some of them can do verbal skills, but very rarely is somebody the best at all of those, and you are definitely in that class. So, Katrina, I want you to do this. We got a lot of young listeners. We actually have dental students listening now. I want them to know who you are.
That's awesome.
Yeah. Who is this person I speak of? Who are you?
Yeah. First of all, I'm Kirk Behrendt's best friend. So I think that's kind of where the story starts. My name is Katrina Sanders. I hail from Milwaukee, Wisconsin. I did my undergrad at the University of Minnesota. Before moving down to Phoenix, Arizona, everybody always asks me, why did you move to Phoenix? And the answer, of course, is you don't have to shovel the sun. So yes, growing up in the Midwest, I was ready for a change of pace, moved down here to Phoenix. And I built a career over the past almost 2 decades. As a clinical dental hygienist, I now work in a large group perio-surgical practice. And I spend the vast majority of my time traveling, speaking on all things perio, oral systemic, patient communication, disease prevention, and really working to help remind dentistry. I don't think that the concept of dentistry being important and the work that we do being something that's critical and valuable for our patients, I don't think that's a new concept. But I think clinicians that get into a clinical practice where patients are questioning their clinical judgment, saying things like, you don't need that information, just clean my teeth, all of those things that I think sometimes it's easy for us to forget about the power that we have in our clinical care and how important and valuable that is. I also am working very hard to be the squeaky wheel that hopefully will get the grease for dentistry being seen as a true extension of medicine, which I believe that we are. And so I think there's so many ways, modalities that we have at our fingertips to be able to do that, which changes the nature of what we do from something that seems elective or optional to something that really is important and a critical aspect, not only of helping our patients achieve health, but improving their qualities of life. Yeah. So here I am on the pod, and it's such an honor to be here. I work very closely with the ACT Dental team, love everybody there. And I just truly appreciate being able to come back to Milwaukee. Y'all always roll out the red carpet for me to be able to do podcasts and educational content. So thank you so much for all you do to bring me back to the Midwest.
Thank you. It's our pleasure. I learned so much stuff. Some of it, I'm like, I got to go back and watch that again. What the heck did she just say? That was so good. So I'm telling you guys, as you listen to this, it's one thing to think some way, but it's a whole different game when you can put it into play and you can help patients understand this and you have the verbal skills. Like, I'm a big fan of verbal skills matter. And so putting all this together is so important. Now, we're going to be talking about the oral systemic myth. And obviously you're doing an amazing course here at our world headquarters that we're so excited about. But let's talk about, what is that? What's the why behind this? So let's get behind the why.
Yeah, let's dive into this. So we've heard of the oral systemic link. And I think it's just been something that has remained very top of mind, on the tip of our tongues. We learn programmatic coursework about it. We listen to podcasts about it. We read articles about it. And gosh, it just seems like every other day there's a new research article coming out that really excites the dental profession, because it creates an opportunity for us to understand what we do inside of the oral systemic link. But there's a myth to all of this. Really? And I believe the biggest myth in all that we know about the oral systemic link is that we think we're doing enough.
Ooh.
Truly.
Tell me more.
And the reality is, if we understand, for example, that 47.2% of our adult patients between the ages of 30 and 79 have periodontitis, and yet you look at the statistic of the number of times that a dental practice actually does perio treatment on those patients versus the number of times that we're performing a prophy on those same diseased patients, you understand that although we know oral inflammation is bad, and through both the direct and indirect pathways that the oral systemic components move in tandem, what are we actually doing about it? We can talk about airway all day long, about looking down the airway of our patients, getting a Mallampati score, learning about snoring habits, asking our patients about the amount of caffeine they're consuming, doing an acronym like STOP BANG, looking at all those things. But unless we're doing something about it, unless we're empowering our patients to capture that referral and being the squeaky wheel to say to that primary care physician, we need to get a sleep test done on this patient, we believe we're doing enough. And the reality is, if it's in the research and we're not doing anything about it, then it stays there. It stays in those journals and in that paperwork, and it doesn't make its way to actually impacting our patients. When we do things like do a very cursory health history exam where we're just skimming everything and going, any changes? Nope. Okay, let's move on. And we don't take the time to stop, pause, look at the medications our patients are on, look at the cardiovascular disease risk components that are riddled throughout that health history exam. If we're telling our patients all day long, I'm concerned about your heart and you need to have this gum disease treatment done to treat your heart, but we're not routinely taking blood pressures on our patients, then the reality is we're not doing enough.
Yeah.
So the myth inside of all of this, Kirk, is the fact that although we know these things and we get so obsessed about the oral systemic link, the myth is rooted, I think, in how does this actually change what we do in clinical practice? How does this actually impact our patients?
Wow. That's like you're pre-blocking a 2-hour podcast because,
Yeah.
and I'm going to be the voice of maybe one of the dentists listening going, Katrina, you don't understand. And so
Yeah,
like,
I don't ever understand. I know. Yeah.
I know. I love this. I love this because at the end of the day, what we believe and how we behave have to come together. Do you know what I mean? And we have to make these adjustments. And this isn't going away. It's morphing into something bigger. So you could say the myth exists, and it does. This is so great. So let's do some myth busting, or how do we approach this? You're the smart one. Like, where do I go from there?
Well, I think we have to begin with. I think we have to begin with what the focus is of the practice.
Right.
That's where it starts. And I will tell you, as a dental hygienist, and this is a very unpopular statement because I do consulting and coaching as well. But I will tell you that the metrics that I believe most dental hygienists who are driven by the oral systemic link and have that as the root of what they do clinically, they are not driven by the numbers. I don't care what your big, hairy, audacious production goal is and what I'm doing to help you achieve that. I don't care what my production goal is for the day and what you expect me to do to produce that. What I do care about are the patients who I am responsible for in moving as close to 100% health as possible. That's the metric. Yeah. And so I do believe that, unfortunately, one of the limitations of what we're doing today is we're using production numbers and even perio percentage scores in a way as our way of identifying a healthy or successful practice. And we can say, if your numbers are this, you have a healthy practice. But my question is, but do you have healthy patients?
Yeah. So
you're doing these numbers, you're making this, but do you have healthy patients? Period.
So is it safe to say, and I know you well enough, I think I know where this is going. If you're a dentist and like this is how you communicate with your hygiene team, your perio numbers have to be here. You got to be there. If you were able to shift your focus and go in the direction you just stated, if my goal as a hygienist was to get my patients 100% into that picture. Now we all have to be aligned on what that picture looks like. Yes. Then the numbers would be the byproduct of all that and less of a deal and less to celebrate because obviously. And one more thing, because I know what you're going to say. You guys, when your perio numbers go up as a result of all this, guess what else goes up? Your restorative numbers.
Everything else. Yes.
So it starts
your patient
with
retention, your restorative numbers, the innovation your patients are asking for, because once the patient is in, they're in your ecosystem and they're experiencing periodontal health. Now they are open to so many other things. So you brought up something that I think is really important that I think most practices believe they have, but they don't. And that is, first and foremost, what does 100% health look like?
Yes. I want to know.
Well, I think it's different, unfortunately, for everybody. And I think one of the most eye-opening things, we've got a practice owner listening, doctors, when you're hosting your next, meeting with your clinical team, ask them to write out, what does 100% health look like? Your hygienists will all say different things. And I think they'll start with very superficial metrics. Like, I think that my patients should not have bone loss. Okay, that's very basic. We need to dive into that a little bit more. Are we talking about patients that maybe have gingivitis? So is gingivitis then considered healthy? Is that considered 100% health? Oh, it's not. So you don't want a patient that has bone loss. You also don't want a patient that has bleeding in the mouth. What else? What if that patient has exposed root surfaces? So now maybe not radiologic bone loss, but they have clinical attachment loss. So is that considered 100% health? What do their vital signs look like? What does the medical history look like of a 100% healthy patient? Because what you're doing is you're creating a different kind of goal. Instead of the goal being, we want to produce $1 million this month, and that's the goal that I'm holding my team to, and you all need to work as hard as possible to get as close to $1 million a month as possible. I know you all are like, what practice are you in where your goal is $1 million a month? I work in perio. But instead of changing that goal, that vision to this is how much money we need to make, the vision needs to be this is where we want all of our patients. So then the talk track becomes, okay, Mrs. Jones is coming in at 8 o'clock tomorrow morning. Last time we noted that she had a 53% bleeding tendency. That was up from last time. And she has 3 cracked teeth. Okay. So now the conversation is, what are we going to do to move this patient as close to 100% health as possible? Then your morning huddle is more driven toward how can we be more problem focused and patient centric? Yeah. How can we identify the challenges the patient has and utilize this information so that essentially our treatment becomes a solution for the patient?
Yeah. I want to go back to something you said. What does this picture look like? You can't standardize that. You're right. Because it really depends on the practice. If I'm a practice owner, I'm limited by what I know and what I've experienced. And
That's
my
right.
team is also limited by what they know. And we're also limited by the fact that we haven't calibrated on this. Now, if you're on this journey and you take a lot of education, you're going to be exposed to more. If you go to Katrina's course, you're going to come back and go, oh my gosh, I see it differently. So I think it would be safe to say, would you agree? Every year, we've got to repaint this picture of what 100%. Can you explain that? I mean, am I on the right track here?
Absolutely. Absolutely. First and foremost, there are so many things that because dentistry is not putting a spotlight on those things, we don't have the opportunity to even fully educate our patients on it. So I did a course last year for the American Academy of Periodontology. The AAP sent me out. They said, we want a hygienist to talk about the perio-systemic link. And it's interesting, in their vernacular, they say perio-systemic because oral systemic is the big umbrella. We've got the perio-systemic link that talks specifically about oral inflammatory conditions and how inflammation in the mouth triggers systemic inflammation. It also talks about how bacteria, bugs that cause periodontal disease and gingivitis and periimplantitis and you name it, can dump into the bloodstream and create all these issues. So when I went out and I spoke on the perio-systemic link, we were diving into all of this research about diabetes and cardiovascular disease and stroke. And those are things that people have known for a significant portion of time. Question number 1 is, just because you know that, do your patients know that? And how are you communicating that to your patients? I think we are so focused around this. We're going to sit back and wait for the primary care physician or the cardiologist to tell us. So one of the things that I unpack in my coursework is you have patients sitting in your chair consistently who present with, I'm just going to use cardiovascular disease as the example, who present with cardiovascular disease risk. I paint the picture like inflammation is a fire, and the more risk assessment pieces that are identified is like a gallon of fuel being tossed on that inflammatory fire. So although your patient may not have checked, yes, I have high blood pressure, and yes, I have high cholesterol, they may not have checked those boxes. But if you're taking blood pressure routinely in the practice, can you screen for high blood pressure? The answer is yes, you can. So you're capturing that information to begin. Even though you are probably not screening for high cholesterol, if your patient has Fordyce granules, which many of us are very trained in how to screen for those things during a head and neck exam. I used to think Fordyce granules were nothing. They weren't a big deal. Well, Fordyce granules are fatty deposits underneath the tissue. And we've seen data that links Fordyce granules to higher cholesterol levels in patients. So if you're seeing a patient whose blood pressure today is higher, they've got Fordyce granules, they already have 2 key risk factors for cardiovascular disease. So am I going to sit and wait for that patient to go to the primary care physician and have the PCP identify that blood pressure? Or am I going to be the one to say, Kirk, I'm concerned. Your blood pressure today is really high. When's the last time you had a doctor look at your blood pressure? When we...
A doctor? Are you asking me, like, specifically?
Yes. Yes.
So last week, I actually went to the doctor twice. So believe it or not, I have...
Twice?
Yeah, I have AFib. So I
Okay.
had to go to my cardiologist and I had to go to my primary care physician. Now, they're both like, I love my primary care and I love my cardiologist. And so I'm in a kind of a different category. But what you're saying is, it's true. Like,
It's true. You have to be able to have that metric. So I had a patient yesterday who came in to see me, and his blood pressure was 157 over 90.
Okay. Wow.
Quite high.
Yeah.
Quite high, like through the roof. Once we get to a 160 in our office, that's where we really start to get concerned.
Right.
I could still treat him that day. So if all I was doing was taking blood pressure just to find out if I can treat him today, and that's where I ended the story, we're missing the opportunity. Here's where the myth comes in.
Yeah.
Then I think I'm doing enough because I have taken your blood pressure. You're okay. It's not quite hit the limit. All right. Let's move on with our treatment.
It's out
of my hands. I'm done. You know what? I'll let your cardiologist or somebody else deal with that. That's the myth, right? That we think that that's what we need to do. So instead, I sat down with my patient and I said, oh my goodness, your blood pressure is high. I flipped around the monitor and I showed him, and he said, yeah, it's because I'm here and my blood pressure, I get nervous when I'm here. And I said to the patient, yeah, that would make sense if your pulse rate was also high, but your pulse rate is stable and your blood pressure is high. So now I'm concerned. So then I asked him, who else is monitoring your blood pressure? And he paused and he said, well, you guys and my doctor, but my blood pressure has never been this high. Well, I went back into our records and it turns out his blood pressure has consistently been that high. This is not a new blood pressure for him. So I said to him, actually, it looks like your blood pressure has been consistently this high every time we've seen you. So when's the last time your primary care physician, a cardiologist, someone else looked at your blood pressure? And he said, you know what? It's probably been 5 years since I've had my blood pressure checked by my doctor.
That's crazy.
Now that's concerning. Isn't that crazy? This patient is on he's on at least 2 medications for high blood pressure. He's a diabetic. He's slightly uncontrolled. He has a history of ablation and myocardial infarction 20 years ago. He's a tobacco smoker, and he's in my perio office about to have surgery.
Yeah, something doesn't, well, okay, keep going.
So none of this adds up with this patient.
I
the
agree.
important piece is I could have done the bare minimum of what the standards and guidelines are for me as a clinician.
Yeah.
Instead, I stopped. This is not right. Because if I'm going to spend all day talking to my patient about how concerning their periodontal condition is and how bad that inflammation is, and if I'm going to use the oral systemic link, which we love to do, if I'm going to use the oral systemic link as kind of the validating, but wait, there's more free shipping and handling. If you get this scaling and root planing done, we're going to reduce your risk for cardiovascular. If I'm going to use that as my case acceptance tool, which by the way, it is a brilliant case acceptance tool, you have to make sure that you fold the entirety of that narrative into the patient care so that my patient understands. I'm talking to you about how concerned I am about your heart health. And now, by the way, I've got a letter that's going out to that patient's cardiologist saying, hello, I saw Mr. Jones yesterday. Here's Mr. Jones's blood pressure. Here's the history of his vital signs. And oh, by the way, I just attached a report of his salivary diagnostics. You're going to see a breakdown of all the gram-negative anaerobic red complex bacteria that are present in his mouth with a chart noting which of these bacteria are implicated in cardiovascular disease. If he has Porphyromonas gingivalis, we know P. gingivalis is collagen binding. That's going to create a challenge. He has high levels of AA. AA loves to create or accelerate the risk of infective endocarditis. So these bacteria, Dr. Cardiologist, who I'm working with, these bacteria are linked back to cardiovascular disease. I'm now creating a closed loop referral system. And one of the reasons why we do that in our office is because I'll tell you, I'm in a perio office. We are a primarily referral-based practice. Patients don't just walk in off the street and go, you know what would be awesome today? Tissue grafting surgery. I would love that. Patients just don't do that. We are a referral-based center. A significant portion of our patients come in from cardiologists and endocrinologists. Why? Because we've created that narrative
Yeah.
where we're helping them understand we're part of your care plan. The important piece in that is it's building the narrative. You think that cardiologist is interacting with cardio risk patients all day long who probably have periodontal conditions? Absolutely. They're interacting with a robust patient population that we should be seeing in tandem.
Right. Now, give us some perspective on the other side of the tandem. What's happening with this research is it's so amazing. So we're caught in the dental world, but great cardio teams now know, hey, they can smell it. They don't even need to do they can go, whoa, I'm picking up on perio here. They know now more than ever what's happening in the hole under your nose has a lot to do with this chest pain and all of these other things. So it's just as important for them to have these kinds of relationships that are all working in the same direction, correct?
You're spot on. And I think that, I just read a quote the other day that said, when you find yourself assuming, prepare to listen and ask more questions.
Ooh, say that again. That's good. Say that again.
Yeah. When you find yourself assuming or making assumptions, take the opportunity to ask more questions and listen.
Why? Give us the why behind that.
The why behind, so there was just an article that was done. I can't remember who wrote it. It was just published last week that dove into the percentage of cardiologists, endocrinologists, the percentage of rheumatologists who have no clue about the oral systemic link. So the reason why I bring this up is my sister's a podiatric surgeon. She's a podiatrist. She sees advanced surgical cases. These are patients who have diabetes. They are so involved in their diabetes that they're having a foot amputated. Do we see similarities to that in dentistry? Yes, of course. When people are having their teeth amputated because of diabetic conditions, right? So she and I did a research poster that we presented for the American Podiatric Medical Association. This was a few years back, where we did a convenience sample survey. We surveyed hundreds of podiatrists and we asked them, before you cut off a toe, part of the foot, the whole foot, or a below knee amputation, before you do that on a diabetic patient, do you ask them if they've seen their dentist? 4% of them said yes. 4%. Now, I have to pause here because you referenced the research, and the data is extremely compelling about how periodontal disease and diabetes are a two-way street. We've seen that if you can control periodontal disease in the mouth, that you can help to reduce hemoglobin A1C in your diabetic patients. 46% of pre-diabetic patients, if all you ever do for them is do periodontal treatment and slow down or reverse their inflammation, 46% of those patients will reverse their pre-diabetes condition back into a state of health within 2 years.
Wow.
Performing periodontal therapy on these patients is a critical aspect of controlling A1C. We've found that performing periodontal treatment will on average reduce the A1C of a patient about 0.5% at a minimum, which is quite similar to what we see when patients are placed on metformin or glyburide. So therapeutically, what we do by performing periodontal treatment is nearly commensurate with some of these medications that our patients are being given. And yet, the doctors who are observing these patients who are so severe, so advanced that they're losing limbs because of diabetes, 4% of them said, yes, I do ask the patient. Now, here's the important piece. 100% of that 4% said the way they ask their patient is with a question on their patient intake form.
Oh my goodness.
So we know just because it's on the intake form and they're asking the question doesn't necessarily mean that they're going, okay, hang on a second. I need to take a pause here. This is so important. I'm a diet, exercise.
That's
dentist,
about as statistically valid as the same question that says, how many drinks do you consume in a week? I'm totally lying on that one.
Right.
You know what I mean?
Exactly.
I have one beer a week,
Right. And that, I think, opens up the dialogue for the other side of it, which is how many times do we have our patients fill out all this stuff and we never call back to it?
Right.
So is it really important? We never put a spotlight on it. And then it makes sense why patients would say, I'm not going to waste my time filling out another updated piece of paperwork for you. Or even better, when I ask my patients any changes to your health history, and they say, nothing that affects my mouth.
Gosh.
So we assume that our healthcare colleagues know, believe, and are implementing those things. The reality is they're not, which dives into a deeper challenge, which is I don't think we can assume that our patients know about the oral systemic link.
That is so good. Okay, now you're opening up the Grand Canyon of like questions here. So,
Yep.
Okay, now help me out of this. So,
Okay,
like that's big. That's big. Okay,
It's huge.
Yeah.
It's huge, right? So, and I think there are ways that we can capture some of this, but it requires us to stop and slow down. Again, I want to go back to the problem statement I brought early on in the podcast recording, which is around if what we're doing is looking at our Dentrix or EagleSoft or Curve or Open, whatever it is, your appointment book, and you're going, okay, these are the procedures today. And if your practice is essentially assigning clinicians to a column and saying, you are responsible for this, these are the things that you need to do. The average clinician, the average hygienist just wants to make sure that they complete the things they need to do so that doctor, practice owner, office manager is happy and we've done the procedures. But what's in between those procedures? A patient comes in for a prophy, a D1110. I implore you to consider that we're doing other things aside from a prophy during that prophy appointment. I took my dog Olive in to have her dental appointment done, and in veterinary, they itemize everything.
Yep.
So she had her radiographs done. Okay, those were listed there. We do that on the human side as well. But they did a head and neck exam. They did periodontal probing. They did gingival inflammation assessments. So they looked at all of those pieces. They looked at her tongue. They looked at her airway. She had a little cyst in the front, so they did a pathology evaluation in that area. So by the end of my little four-legged daughter's appointment, I had an itemized breakdown of everything that happened. This wasn't just a dental cleaning appointment. She had a comprehensive survey. And in fact, before she even had her dental appointment, they did blood work. They did a urine analysis. I mean, I'm not saying that we're going to be doing urine analysis on our patients, but what I do mean to say is she had a comprehensive evaluation looking at the fact that if she did have disease in her mouth, it might be connected to the rest of the body. Today, as of the recording of this podcast, we have the ability to do things like integrate the use of AI to read bony changes in our patients. We have the ability to use salivary diagnostics. If my dog goes into the vet with an ear infection, the first thing they do is take a swab, they look at it under a microscope and identify what microbes are happening. But in dentistry, we're not doing those things. That is not a standard practice for us. Today in dentistry, we understand that airway is a critical aspect and opportunity in our role of comprehensive patient care outside of the perio-systemic link. So we take it back and we go, Katrina, RDH. Is my job to see you, Kirk, and do your 4 bite wings, your prophy, and sell you a fluoride? Or is my job to guide you through true oral systemic health prevention, where I'm sitting down and I'm looking at the top and I'm asking you not only about the medical conditions you might have, but asking you about family history, which is going to give me risk profiles, asking you about symptoms. My diabetic patients who are diabetic but don't know they are will have extreme thirst. They'll notice swelling in their limbs. We know these things to be true.
Right.
I ask my patients about what their diet is, not so I can check to see how many fermentable carbohydrates they're consuming for decay risk. I'm asking them about their diet because I want to know if nutritional deficiencies might play a role in the inflammation that I am seeing in their mouth. It changes the dynamic or the conversation from transactional and procedural based. You're here for this, so I'm going to give you this. You're here for this, I'm going to give you this. To a relationship-based conversation where now we're saying, Kirk, I want you to be a patient in our practice for life.
Yeah.
And by the way, patients are living longer They're living longer with their natural teeth. So we are observing them in hygiene chairs, in dental practices over a long spectrum of time. But if you look at the spectrum of life and the spectrum of quality of life, I will tell you, patients are living longer, but they're more specifically dying longer. The amount of time at the end of their life that they are experiencing severe chronic diseases that are negatively impacting their quality of life, we recognize that we have a role in that. So the conversation really kind of curls back to, instead of, all right, so what are you going to do on your 8 a.m. patient named Kirk this morning? The conversation is, what opportunities do we have to help improve Kirk's health?
Love it. There are people that fix teeth and there are people that change lives. It's not the same business.
That's right.
This is so
That's
cool.
right.
And you have to believe patients will get it. I've never shared this in the podcast, but I said this to Ross Nash last week. He's like, let me see your smile. And he's an amazing cosmetic dentist. I go, Ross, you'll love this. I have all of my original teeth. And that's one of my goals. I don't ever want a crown. I do have some composites. Now, that's me, but here's the point. I had a hygienist that believed in me and said, this is not going the right way. When I was young, I've been through ortho 3 times. I didn't want to do that. I had no desire to ever do that. But you can get through to the worst. I didn't even go to the dentist as a kid because we couldn't afford it. Do you know what I mean? Like, So if you care enough, you'll get through to even the toughest patients like me, and they might carry that legacy forward. So like, I think that's the biggest reward. And you talk about work that's meaningful. Like we have so many.
Yes.
That's a big conversation is like, we spend 30%. Katrina, do you know this? Because you're the stats king, but I'm going to throw one queen. Do you know you spend 30% of your life at work?
Really?
Wouldn't you want it to be meaningful, impactful?
100%.
Like, why would you ever want it to be transactional? Wouldn't you want it to be transformational? And it starts with how you think. It's not what you do. You have to first start to think. So I'm nervous. This could go on for another hour. So we have to do this. We're going to continue this. And then I'm going to give you guys a little precursor to another show. In a future show, I'm not going to tell you where it is, but we're going to address specifically the hygiene shortages in the dental marketplace. So be on the lookout for that. But let's do this first. I want you to talk about the course that's coming up. I want you to talk about where people can find more about you. But before we do that, let's wrap this up with some final thoughts for what we just talked about. Put this in a little bow for us today before we go on to that.
So here we're starting to see a trend or a shift in our patient population. Patients now more than ever feel unheard, and they are seeking ways of empowering themselves with knowledge about themselves. We are in an age now where disease prevention is a big focus. People are taking supplements. They're learning about things on TikTok from influencers about, salivary tests they can do to learn about if they can eat tomatoes and green bell peppers or not. People are curious, and we are beginning to recognize that there is a huge void in the patient support system. They're doing things like doing full body MRIs just to look around for things. People are empowering themselves with risk assessment knowledge. They're curious and doing 23andMe because they want to be able to understand their risk, their heritage, their position in the world. We have an opportunity as dental providers and those of us who are focused on the preventive mission that the oral systemic link is, to really change the dynamic of what we've done in the past in order to step out of this myth of assuming that we're doing enough. We have to start listening and we have to start asking. And in order to be able to do that, we have to know how we as oral health care providers can help shape a high quality future for our patients. And so I'm so thrilled to be joining the ACT Dental team alongside my sister, actually, Dr. Elizabeth Sanders. So this is going to be a sister ACT. And she and I are co-presenting the course titled the oral systemic myth on Friday, August 1st, 2025, in fabulous Milwaukee, Wisconsin, where we're going to dive into this. And the goal in bringing my sister into the conversation is to learn about what our medical colleagues are starting to do to begin transforming healthcare and identify the ways in which dentistry can align with what our healthcare colleagues are doing to fully create a patient supportive expression of our work. So I'll tell you, it's an exciting time to be doing what we're doing. And to your point, Kirk, with the changes that we're seeing in the workforce shortages, particularly for hygienists, having deep dive conversations, impactful conversations like this, and creating a mission statement and series of core values in a practice surrounding patient health creates a gorgeous attractant, not only for patients who care about whole body health, but also for providers who want to step into what that next chapter of excellence looks like in dentistry.
So well said. Drop the mic. That's so good.
Boom.
Awesome. All right. So here's how this works. I am going to put a link. If you're not taking notes, don't worry. We take notes for you. You can flip up to the show notes wherever you're consuming the podcast on iTunes, Spotify, Stitcher, doesn't matter. You're going to see links to what Katrina just mentioned, and I am going to encourage you to register for the course. I promise you, you will absolutely love it. I also want people to know, Katrina, I'm listening to this. How do I find out more about you? Where do I go? Like, what do you do? How do I follow more of what you do?
Yeah, thank you so much. So always feel free to find me on social media. I'm on Instagram at the Dental WINEgenist. So you'll find me there. And I post lots of educational content. I'm on podcasts, writing articles all the time. So I will share all of my content there. You can subscribe to my newsletter on there where I send information about where I'm going to be, what I'm doing, how you can engage with my content. Feel free to find me on LinkedIn, Katrina Sanders. Find me on Facebook, Katrina Sanders. And if you have any questions, inquiries, have an interest in learning more, or would like to collaborate, bring me in to work with your study club, anything like that, you can find me online at www.katrinasanders.com.
Love it. I'm going to say this. If you have a study club and you haven't had her speak, what are you thinking? Like, she will blow everybody away. Now, I feel bad. Like, I was raving about you at the beginning of the podcast, but I left out one of my favorite things. You are a sommelier. Did I say that right?
That's right. Yes, that's right.
Not only are you fun to listen to, educational, verbal skills, like it'll blow your mind, but she serves wine in her courses. Nobody does that legally, right?
That's right. In fact, I have to do a shout out to Dr. Ward out of Kansas City. Dr. Ward listens to your podcast, by the way.
She's amazing.
She is so spectacular. She blows my mind, and she's like, oh, it's not a big deal, but she's really incredible. She's a periodontist who opened up an airway clinic because she just saw the need, and she's just amazing. So she brought me out to Kansas City, and I just did a wine tasting with her. But yes, there are so many amazing opportunities to really blend together education and engagement with people. And I'll tell you, when you serve them wine, that's where the secret sauce comes out. That's where you start to learn about the true pain points and challenges that your clinicians are experiencing and trying to implement a lot of this. So wine brings a beautiful spin to all of it, for sure.
It does. And Dr. Ward is amazing. Shout out to you. One more thing that wine does is it makes you say to yourself while you're drinking wine in Katrina's course, did she just say that out loud? Like, oh my goodness. It's wildly entertaining. So Katrina, I cannot thank you enough. So thanks for being on.
Likewise.
Awesome.
Thank you for having me.
It is my pleasure. And you're going to come back again and again. You don't even have a choice. It's called voluntolding. I love that.
That's right. Yeah. Happy to do it.
Awesome. All right. Well, you stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show podcast. I told you that was going to be good. And she delivered. So we're going to have her back again and again and again. Make sure you check out the course. Again, the link is in the show notes. Can't make it any easier than that. Check it out. Make sure you follow her on social media. She actually has an extraordinary social media presence. It's pretty cool. So Again, you can find all those links there. So keep showing up, keep spreading the word. We're so grateful. And until you guys hear from us next time or you see us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.